Thanks, Peter. Thanks for the invitation. It's really a pleasure to be here and see familiar faces. So I was a bit surprised when I was asked to talk about SPECT. I'm more of a PET guy, but I'm going to try to do something different, maybe a bit provocative, and hopefully you won't be mad at me at the end of the 20 minutes. Here are my disclosures. So if we go way back 15 years ago, it's interesting to appreciate that the history of modern cardiology and nuclear medicine is really intertwined. We've all seen this graph or different version of this graph, which was produced by Gould in '74, and it's showing that it's showing the relationship between percent stenosis of a coronary artery and the abnormal or normal regional distribution. It shows that if you need a stenosis of 50% to 70% to cause impairment in myocardial blood flow at high flow. And this is actually where the 70% threshold we still use today in angiography and coronary CTA comes from. Around the same time, Zaret and colleagues used potassium-43, and they did the first rest and stress study describing what we know now as reversible perfusion defects in patients with obstructive coronary artery disease. We've moved away, obviously, from potassium-43. We went with thallium, a potassium analog, and then technetium-based tracer. We moved from rectilinear scanner, as you see here, to planar images, to SPECT, to SPECT-CT, and really the 1990s and 2000 were the golden age of myocardial perfusion imaging with SPECT. Another very famous graphic here we've all seen from Achamovich, showing that using SPECT we can predict who's going to benefit from revascularization and who's going to benefit more from medical therapy. And that was published more than 20 years ago, and we're still using that when we're reading SPECT studies, because if we're seeing moderate to severe ischemia, we assume that there's more than 10–12% of reversible perfusion defect, and cardiologists tend to go to the cath lab with these patients, whereas if we only have mild or no ischemia, then we think about medical treatment. And during that golden era, we saw a trend where we're scanning more and more patients with perfusion imaging, and we saw lower risk patient referred to us, and this resulted in lower percent of abnormal studies and ischemia on imaging. So now we're in 2024. Where are we at with perfusion imaging with SPECT? The golden age is behind us, obviously. And we are facing several challenges. And today I'm going to discuss 3 challenges we're facing and hopefully some solution. So the first challenge, and this is a big one, and if you've been following the news in cardiology, you're aware of that, is the first question is ischemia testing is even relevant in 2024? We looked at trials like the ischemia trial that was published 4 years ago, showing no benefit in patient with stable coronary artery disease and moderate to severe ischemia. There was no benefit to revascularize these patients. They were doing just as well with medical therapy. You can argue that the study was not perfect. There was a selection bias. There was a lot of crossover between the conservative and invasive strategy. Ischemia testing was really suboptimal. A lot of patients actually just had a treadmill stress test, and they were enrolled based on that. But nonetheless, the literature in cardiology is really pointing towards, conservative and invasive strategies are equivalent. If we looked at other randomized controlled trials that looked at the benefit of revascularization, those that are based on functional assessment of ischemia, they do confirm the value of these tests. So the most famous one are the FAME trials that confirm that ischemia-guided intervention using FFR worked in terms of death MI and revascularization. As such, we can think that any test that has been validated against FFR, just like SPECT imaging, SPECT myocardial perfusion imaging is also good to guide patient. Krishna Patel and Tim Bateman published a bunch of papers using PET and the prognostic value, and they reproduced the Achamovich graphic, but this time with global myocardial blood flow reserve, an index of function. And they observed that if your flow reserve is below 1.8, 2.0, then you benefit more from revascularization, whereas if it's greater than 2, you benefit more from medical therapy. But these are observational retrospective studies. They're not randomized controlled trials. What we're seeing in cardiology right now is really a paradigm shift. We're not focusing so much on prolonging life. We're focusing more on quality of life, improvements of symptoms. And studies like ischemia showed that you actually improve symptoms with revascularization and quality of life. So in that sense, myocardial perfusion imaging is still very relevant because you still need to identify those patients that have flow-limiting lesions who would benefit in terms of symptoms of revascularization. And it's not, if the patients we're seeing now, they have multiple stenosis. Which one is critical? Which one is the culprit? How many should we revascularize? So myocardial perfusion imaging is still very, very relevant to answer these questions and to have complete revascularization in these patients. So even though we're seeing less and less benefit from revascularization compared to medical therapy because of all the improvement in the medical therapy we've observed in the last 20 years, it is still relevant to identify patients who will benefit in terms of symptoms from revascularization. The second big challenge we're facing is coronary CT angiography. I just picked a random image on Google Image to show you how beautiful these images look, right? You're seeing these high resolution pictures, you're seeing the coronary arteries, and you're comparing that to a SPECT perfusion, a blurry SPECT perfusion with your 1 centimeter spatial resolution, and how can we compete with that, right? We know that CCTA is very quick. If you apply it in a population of patients with acute chest pain in the emergency department, you can speed up their management. You can have an answer quickly. You can discharge them quickly. So in that sense, it's a very interesting test. However, it's not a perfect test. The test is performing extremely well in patients with very low risk of coronary artery disease, but it's not performing so well in those with intermediate and higher risk. There's a lot of false positive, lots of equivocal studies. It's overcalling, and it results in increased downstream testing. So we're seeing more and more downstream testing when we have a CCTA approach. And we're seeing more cath, more revascularization, but no improvement in outcomes. So we're going the other way, right? I'm just telling you that we should be cathing less and revascularizing less, but with CCTA, we're doing it more. So in that sense, it's not a perfect test. I looked at 1 year of data at my center. This is from 2001. So I looked at 1 year of CCTA and look at these numbers. 30% of the scans done at my center, and we're not like, the radiologists are very, very competent. They are all fellow trained and expert in CCTA. And 30% of cases were either non-diagnostic or equivocal and required more testing. And we see them in our lab, and they get myocardial perfusion imaging. And the cardiologists are telling us, well, we do see a lesion there, but is it causing the symptoms? I don't know. So myocardial perfusion imaging can answer these questions and is still very, very relevant. However, as I said, it's mostly useful in patients with low risk. If you have high-risk patients, and I think this is why the numbers here are so high, 30%, because at my center, patients tend to have moderate to high risk to start with. If you go to a low-risk center, probably the numbers are not that bad. And this is probably why emergency doctors, they love that test. They really do love their CCTA because it provides an answer very quickly, and they don't really care about the downstream effect of a test. They don't care about whether the patient will have a cath that's necessary or not. They want to know, do I refer to cardiology or no, right? And they want to get rid of their waiting list, or not their waiting list, but they want to get rid of the patients. They want to move fast. So this is why CCTAs are very appreciated by emergency doctors. If we looked at the trends in terms of numbers, yes, the number of SPECT perfusion study has decreased in the last 10 years. Yes, the number of CCTA has increased, but it's nowhere near. You have to be careful here. The y-axis is a bit tricky, but we're doing 15 times less CCTA compared to SPECT in the United States in 2022. Interestingly, you can see that they're doing more PET perfusion than they are doing coronary CTA in the States. We have similar numbers in Canada. I couldn't find more recent numbers, but again, CCTA remains more marginal compared to myocardial perfusion imaging. So I'm telling you that lower risk patients, they tend to do well with coronary CT, and coronary CT is not doing so well with moderate to high risk patients. And what's going to happen is we're going to have another shift in population, the population that's referred to us, obviously. And that's, I think, the third challenge we're facing. We'll have more moderate to higher pre-test probability. We'll have bigger patients, heavier patients. We know our test is less effective in that population. We know that we're affected by attenuation artifact. We'll also have more pharmacological stress. And this is a trend we're seeing worldwide, more pharmacological stress. We know that if we're doing an exercise MPI, we have a good warranty period. We teach our resident, or you have a very low risk, below 1% of event at one year. But there's the caveat that if you're doing a pharmacological stress, it's not working as well, right? Let me scare you with a case, and all the residents that rotate at my center, they see cases like that. On the left side, you have a perfusion study with diprotamol, completely normal. No ischemia, no scar. The same patient was scanned a few days later with dobutamine, and you can see this is clearly abnormal. You don't need to do a 5-year residency program to figure this out. How did we know that we needed to do a dobutamine in that patient? Well, we have with PET the flow reserve. We can measure the flow at rest, the flow at stress, and know if they responded or not to pharmacological stress. And we identified that this patient was a non-responder, and we actually had 2 resting studies. So the test was not diagnostic. If I did a MIB or a tetrophosphate on a patient, my conclusion would be normal. I did a PET, I had the answer non-diagnostic study, and I did a dobutamine, confirmed that there was significant coronary artery disease. This is a blind spot of myocardial perfusion imaging with SPECT and pharmacological stress. You might argue or tell me that, well, we have other ways of knowing whether they responded or not. We can look at blood pressure, we can look at heart rate. Well, I have bad news for you. We actually looked at that. Vincent, a MSc student with me, looked at that. We looked at 4,000 patients with very low risk of coronary artery disease. No calcium, no diabetes, no history of cardiac disease, normal perfusion, 2 risk factors or less. Very, very low risk patients, right? 3.1% had low flow reserve, suggestive of poor response to pharmacological stress. In that population, 3% had probably suboptimal studies. And among them, a third had hemodynamic response. Systolic blood pressure decreased by 10, heart rate increased by 10, and 10% had actually both. So it's not it helps, but it's not perfect. So it remains a blind spot for us. So we've talked about some challenges, the fact that we're questioning the need for ischemia testing. We're challenged by CCTA and their beautiful images, and the fact that we're seeing a population shift where our test is probably less effective. Where do we go from here? If you ask anyone who's done PET perfusion imaging, they would tell you without hesitation that it's the way to go. It's the way of the future. You have to have a plan for the medium-long term to do PET perfusion imaging, and that's the plan. It's been shown to be cost-effective in the population we're disserving. It's been shown to be faster, to have less downstream testing. And now we have new tracers that are in the pipeline and coming in the market. We have flurpiridaz that should receive FDA approval by the end of the year, and you won't need a generator or cyclotron to do PET perfusion imaging anymore. Now, realistically, I understand that not everyone can do PET perfusion imaging today. We don't have the camera time. We may not have the camera at all. It's not possible for everyone to do it, but I strongly believe that everyone should be striving to do PET, and that should be a goal. We always think about PET in terms of oncology, but there's more to PET than just oncology. Ran showed a slide showing that coronary artery disease remains #1 killer worldwide. So it is relevant, and we're helping these patients. So everyone should be pushing and fighting to do cardiac PET because that's the best test. And in 30 years, I don't think we're going to be doing much, maybe anymore. And that's important. But I do believe that we will still be doing PET perfusion. So where do we go from here? Well, we should be aiming at doing PET someday. But what do we do in the meantime? Well, we do everything we can to have the best test possible with what we have. That means doing attenuation correction if you have a CT. That means doing prone imaging if you don't have a CT and attenuation correction. That means getting dedicated cardiac SPECT camera if you can do it. It also means reporting the calcium score, and that's really important, something I want to quickly talk about. For some reason, people are hesitant to talk about coronary calcification when they read myocardial perfusion imaging, and they have all that information as SPECT. They're not shy to say that there's a lung nodule in the right upper lobe if they see it, but coronary calcification is very, very important to report. If you take patients with normal perfusion imaging with SPECT, and you have a high coronary calcium burden, we know that they're not doing well in the long term. And as soon as 3 years, the Kaplan-Meier curves are actually separating. So it's really important to recognize that. It helps with your confidence in reading. If you have a 70-year-old patient with something weird on the scan, you don't quite believe it, but the calcium score is 0, you'll be more comfortable not calling it. If you have a 40-year-old patient with a calcium score of 50, that's completely abnormal, and you're going to be more sensitive in these cases. And it might help you also identify patients with higher risk. I think the most important point of adding calcium is actually you add a whole dimension to your report. You're no longer thinking about whether there is obstructive or non-obstructive CAD. You have all the dimension of non-obstructive CAD, yes or no. So you have obstructive CAD, I need to do an angiography and treat the patient maybe with revascularization, but you also have the dimension of non-obstructive CAD. Well, the calcium score is high, so the patient needs medical therapy, and he will receive medical therapy, and that's going to change the outcome of the patient. The calcium is, there's no coronary calcium, well, there's no CAD, you don't need to treat the patient. So that's important. And also, you want to see if you can do myocardial blood flow quantification with SPECT and identify those non-responders. I don't believe it's going to be ever accurate enough to diagnose microvascular disease, but most likely it will be good enough to say, well, the patient responded or not to pharmacological stress. So I'm going to conclude with that. I think that we should all be aspiring to do PET perfusion on the long term, ideally medium term. But meanwhile, SPECT is still very useful, very clinically relevant. And to keep it that way, we should really strive to perform it optimally. I thank you for your attention.
Thank you.